Okay, so well, Michael, just congratulations for your lecture. So you may know, but I'm just started my sabbatical. But I think I'm going to do a fellowship after my sabbatical at your place. So during my sabbatical, I'm going to come down and do a fellowship. So I was assigned this lecture about this major breakthrough of spinal deformity surgery. So as you know, we all just go in a chat GPT to find some solution. So I went in chat GPT and typed in my lecture assignment, and that's what I got. And at first I could notice a few mistakes about the date of Paul Harrington use of his rod, and a couple of mistakes, and it was very, very minimal. So I thought, well, we still have some room before a chat GPT takes over everything of what we're doing. So that's probably a good news, because that's only what we were given. So the history of spine deformity surgery starts with Hippocrates a long time ago. When everybody is familiar with these slides of hanging the patient by the feet, or just try to crank him on the Hippocrates frame to get more correction of the deformity. And then how do you get advanced? However, we have to move the 19th century to see a first scoliosis surgery being performed by a French guy named Jules René Guérin in 1865. He was cutting the muscle and tendon on the concavity of the curve. He did a huge number of patients, but the result, as you could expect, was very bad, and he even got sued for this. More serious was in the beginning of the 20th century. Russell Hibbs, a New York Orthopedic Hospital, did the first spine fusion for scoliosis in a cast, and this was one of the trademark of the scoliosis surgery for sometimes. Until the major breakthrough happened, Paul Harrington in 1962 came with the brilliant idea to get the correction of the curve by a rod inserted with two hooks, and would distract between the two hooks, one infralaminar and one pedicle hook at the top, and get the correction through distraction. This was done initially for patients who had the poliomyelitis and scoliosis, and this was further extended to patients with idiopathic scoliosis. And this was the definitely the way to do the spine surgery for the next few decades. Then in 1980, Eduardo Lucchi came with the first segmental instrumentation consisted of sublaminar wire. And I think this has to be known, this technique, even though we all put pedicle screws, because in some cases, you may want to supplement to construct with a sublaminar wire, or be able to pull on the apex. For instance, if you don't have any pedicle screw possible, the pedicle are too small, you should know about this technique of putting sublaminar wires in the spine. This was further extended with the Lucchi Galveston with the pelvic fixation a little bit later, just 10 years afterwards, but still with the principle of Lucchi with multiple segmental instrumentation. In 1983, Cottrell and Dubousset from France came with the CD instrumentation, which was another revolution in spine surgery. And as a matter of fact, all the systems we're using now derived from the Cottrell-Dubousset instrumentation system. Whichever company has it, it's still the basis of the instrumentation comes from the Cottrell-Dubousset instrumentation 1983. And they describe the way to correct the scoliosis by derotating the concave rod to bring the curve in the sagittal, the rod in the sagittal plane, and inducing kyphosis at the same time. They would get the correction of the scoliosis. And this is on a case you could see with multiple hooks. So you had to plan the surgery before with where you would distract the curve, where would you compress the curve to get some correction. And this we had to think before going into the spine, how we're going to correct, and we had to get some strategy to correct the spine deformity, and that was started in the 1890s for several decades. At the same time, the pedicle screw instrumentation was used by Wakami under the leadership of Jean Judet in 1970. Robert Wakami started to use pedicle screws initially for fractures and degenerative spine, and this was later used for scoliosis, and this was popularized with Arthur Steffi in the 1986, despite many litigation and lawsuit for pedicle screw instrumentation until it became the standard of care pedicle screw instrumentation. So, but in the 1990s, there was a huge litigation history of pedicle screw in the United States, despite the fact that it was very helpful. It was the good way to treat the patient, and eventually it became the standard of care. This allowed to take care of scoliosis in a segmented fashion with the pedicle screws at a strategic point or all over the place, or if you want to have increase the density of the instrumentation on the concave side and the convex side. But in most cases, it's even not necessary to get the instrumentation at every single level in idiopathic scoliosis and young healthy teenager, as opposed to the adult, which are just another animals. On the same thing, we should also talk about the anterior surgery, which, as a matter of fact, was popularized initially by Hoxton in Hong Kong, who was treating lots of tuberculosis, and he devised what's called now the Hong Kong operation, which consisted for the tuberculosis to go in the front of the spine. They breed the osteomyelitis, the TB, just remove the disc and do the compression anteriorly, and then afterwards insert the ribs to enhance the fusion, and this allowed to treat the tuberculosis successfully, and he had a huge series for what's known the Hong Kong operation. Later, this surgery was extended to the anterior surgery of the spine for scoliosis. Alan Dwyer from Australia in 1969 came with the concept of the anterior thoracolumbar approach for the treatment of the thoracolumbar curve using a cable. You insert the screw over staples at multiple different levels, and then you would tension the cable starting either proximally or distally, depending on where you are on the curve. And this principle of compression is still the basis of what's used for the vertebral body tethering that we can see with using not a cable but using mesh, not a mesh, but the tension. Then Klaus Dilke in Germany in 1976 improved the Dwyer system. He was not using a cable. We were using a small 3.5 millimeter rod that with the rotating system that would get more stability of the curve, would give a little bit better sagittal profile, but to still lead to some kyphosis despite the rotation of the system. But definitely it was very powerful to correct the deformity. A modern adaptation of this system was the Helsinki and the like instrumentation, which consists now, if you still want to use this anterior approach to treat thoracolumbar curve, you would use two rods now and cages, and you would give, according to the John Hall principle to the John Hall principle and the Boston group, you give a slight overcorrection of the curve, and this allows you to save one level distally, and this it gives a beautiful result in good selected cases. The rule of thumb for correction of this curve: if the apex is a disc, you fuse 2 level above, 2 level below. If the apex is vertebral, you can do very short and 1 level above, 1 level below, which gives you a very short fixation and a good correction of the scoliosis. I think I have to go back. Can you excuse me. So then just came an extension of the anterior surgery. I came with a brilliant idea of vertebral body tethering, which I don't have any experience as I'm not doing that much pediatric anymore. that was by Randy Betts, who divided this system to get some bony growth on the apex of the curve. So excuse me. So the extension of the anterior surgery came also afterwards with the lateral surgery, whether you do it with the OLIF or a transpsoas surgery, which allows you to give a fantastic correction, especially if you resect the anterior longitudinal ligament completely. This gives you a perfect correction of the curve, and this was a big advance in the treatment of the deformity. If we look to the different osteotomies, definitely there's been a huge advance in the way we treat the patient, being able to perform osteotomy, which can be very powerful. The pedicle subtraction osteotomy was divided by Thomason in 1985, so that's a long time ago, for ankylosing spondylitis, and then it became popular in North America in at the beginning of this century, where we started to do more and more pedicular subtraction osteotomy. So this is a case you can see a severe ankylosing spondylitis who had the previous spine fusion for the probably a fracture. I think that's what he had. And as the spine is all fused, the only way to take care of the problem is to do a pedicle subtraction osteotomy, which in this case had to be done at 2 levels because he has a thoracoid deformity and he has also a lumbar deformity. So we took him to the OR, some hard time to position him because of the deformity, and perform the 2-level pedicle subtraction osteotomy, one at L4, another one at L1, which allowed us to get the correction of the alignment. And you can see him before and after the surgery with the restoration of his sagittal alignment and his horizontal gaze back to normal. Three-column osteotomy was extended to the concept of vertebral column resection, where you remove completely one vertebral body. It was initially described in 1922, as a matter of fact, when you look at the literature. Then afterwards, Leatherman, Lukey did some cases. Bradford was doing them anteriorly and posteriorly. But it's Sook from Korea which popularized the posterior vertebral column resection in 2002. As a matter of fact, I had a chance to visit him during my scholars research traveling fellowship in 1997, and he was already performing this posterior vertebral column resection, and we had the demonstration of one of them, and it was absolutely brilliant. And then Lanky in North America just published a lot and performed absolutely a huge number of these procedures to get a correction. And this is some example of posterior vertebral PVCR that we can do in patients with a cervical spine deformity with a previous fusion. As you can see, lack of horizontal gaze. And the way I did a pedicle vertebral column resection in the thoracic spine to get the correction. Eventually, this patient was still malaligned, but we knew it, and we did pedicle subtraction osteotomy at the level of the lumbar spine to get it perfectly straight. So this was stage first VCR at the upper thoracic spine, and then pedicle subtraction osteotomy a year later. You can address a very difficult problem like this patient who has also cervicothoracic deformity, and on the X-ray you don't understand anything because everything is overlapping each other, but we could apply the same principle in this patient, the previous one, and do a vertebral column resection at the apex of the curve. And this patient, I told her that we would fix only the neck initially, and then we'll address the lumbar spine later if she wants to, but she's so happy that she's not interested for the moment. So another example of VCR, as you can see, in a young patient, 4 years of age, I treated during my outreach mission to Trinidad, who just had a very spastic issue with the congenital dislocation of the spine, resected the apex of the curve from posterior, inserted a Harms cage and 4 rods, 4 cervical rods, as the patient was 4 years of age. And she even had some recuperation of neurologic status. In terms of breakthrough, we have the cage technology, and I would give credit to Harms, Jürgen Harms, to have come up with the Harms cage, and then this was followed by the expandable cages, and then more recently with the hyperlordotic cages. We've seen some example of Harms cages. I want to show you another example of a patient who had a Ewing sarcoma that was irradiated. He had kyphosis following this. He had an insertion of posterior rods. He did fine for 5 years, and after 5 years, he broke his rods. Wow. And he came to see me, do whatever it takes, but I don't want to ever have to come back again. So we thought that because of radiation therapy, it would require to have anterior support, which we did with this multiple anterior discectomy and insertion of Harms cage. And then posteriorly, we revised the instrumentation and put 4 rods to make sure that it wouldn't have to come back for further surgery. Now comes the hyperlordotic cages, which I think became a game changer in the spinal deformity, which made the surgery that required a 3-column osteotomy, like a PSO VCR, necessary. And now we have a very simple way to address the problem. It only takes, in most cases, a verging discus space in the front. And if you have a verging discus space in the front, whether you have a posterior spine fusion in the back or not, you just go for it, go insert a hyperlordotic cage in the front. This is very easy. And then you resect the ALL, you insert your cage, and posteriorly you may add a Smith-Peterson osteotomy, and you get the whole correction you want. This is a patient who had a classic flat back syndrome after a Harrington rod. And you can see she's decompensated. The surgeon wanted to do a pedicle subtraction osteotomy in her case, but I find this is more complex. This surgery we went in the front, inserted hyperlordotic cages. In the back, I did a Smith-Peterson osteotomy, and I get the whole correction, and the surgery was done in 4 hours. We linked to the previous Harrington rod. Patient left on post-op 3. This is not minimally invasive, but for the patient, it's a very effective surgery without too much insult to the patient, much easier than the 3-column osteotomies. Another breakthrough on the spine was the advent of spinal cord monitoring. The somatosensory evoked potential was studied in the 70s, and the motor evoked potential came in the 1980s, and this was a game changer. This would allow us to do all types of complex spine deformity, which we would not dare to do before because we had a constant control of the spinal cord. And to a point, this is so useful for patient safety that we have algorithm how to behave when we have loss of data in the OR. And this at one point was just posted in my OR theater, and then just for a reason why I ignore somebody take it down, I didn't get it reposted, but I had all the algorithm which is this one, what to do in case of intra-op monitoring loss. I would strongly encourage you to have it as well in your OR, so the team can respond to it when you have a loss of data. This was another breakthrough and a game changer in spinal deformity surgery. EOS machine initially done for pediatric patients, so they would reduce the amount of radiation to the spine 5-fold, so than classic 3-foot X-rays. I think it's been extremely useful to understand the spinal deformity. I'm just going to show you an example of this patient who has a flat back, and she complained of low back pain, mostly low back pain, and I thought that I could address the issue with only posterior surgery. And I didn't pay attention, as a matter of fact, to the fact that the patient had some hip flexion contracture that you can see under the dotted line. If you can see that the pelvis is vertical, normally the pelvis should be retroverted in her case. If you had a flat back deformity, you retrovert your pelvis unless you have a hip flexion contracture. In her case, I just ignored this hip flexion contracture. I thought it was not going to be important. I did my correction with lateral cages and tried to get the patient straight. And I had only a very small improvement of sagittal imbalance. But then she started to, it was doing a little bit better for back pain, but then she started to have, excuse me, can we, let's go back. And then she started to have some hip pain because we knew she had hip arthropathy on both her sides. So she gets total hip replacement on one side, and we can see that she improved a little bit more sagittal alignment through the EOS, view in the EOS system. And then she gets a second hip down, the first hip down, second hip down, and then she has a perfect sagittal alignment. So this is fantastic tool. So you're able to understand the pathology of the spine, the pathology of the hips, the pathology of the knees, and what's the driver of the spine deformity, and because they're often combined. And this is again the same patient, as you can see, before a surgery, after my spine surgery initially, after a first total hip replacement, after a second hip replacement. And maybe you're going to tell me, why didn't you do both hip replacement first? It was difficult to say because she came from back pain, which I thought was related to flat back. And this was really a very good eye-opener for me, so to have a better understanding of the deformity. Now, for pelvic fixation, we had a different breakthrough over the years. In 1980s came the Galveston, which I show you an example. That was a Luque Galveston, which provided a very good pelvic fixation, but it was often not enough, especially in the adult patient, to provide a long-term fixation. You often had some issue like windshield wipers, that the rods, bent rods, would move into the pelvis. And to screw fixation, the pelvis, and then now in the adult, often 4 rods, quad rods into the pelvis, as despite all the instrumentation, all the fusion we're doing, we still have pseudoarthrosis and rod breakage in this patient. And why you have to insert 4 rods in some of these patients? Because we have, unfortunately, to deal with the patient who are overweight and are not in great shape, and the forces on the rods are tremendous. Whatever you're doing with anterior surgery, posterior surgery, BMP, if you don't have a strong construct, especially at the lumbosacral spine, your system is prone to failure. There's been a report from Seattle group, as a matter of fact, from you guys, that reported a rod breakage incidence of is it 10 or 15% of rod breakage despite solid posterior fusion in the adult deformity world. So if you only do 1 or 2 deformity a year, you may not want to put the 4 rods, you may not want find it necessary. But if you're doing like a 70 to 100 adult deformity every year, and you only put 2 rods, all of your clinic, you're going to see 2 or 3 patients with a rod breakage. Even though if you put BMP, you've done the nice decortication, use all type of bone graft, and you've done anterior column support. So this has come over the years. For me, at my standard of care, so in the adult patients, I would put 4 rods, and I would stagger on the top, not to induce too much rigidity on the top of the spine. And this is a patient who had to do 2 PSO, and you can see that we have a satellite rods at the level of the PSO, and which span to the top because I had to do the second PSO, and the patient did very well, didn't break her rods. and she has a total of 6 rods, 2 rods satellite with a PSO, and 4 rods construct to hold her up to the rest of the spine. But you could see that she was obese to the rest. Now, looking forward, obviously you have the MIS technique, which was we had a fantastic talk by Michael just before that. I'm not going to talk that much about the MIS. You have navigation, robotics, artificial intelligence, machine learning, and ChatGPT. I give you what I think of ChatGPT for the moment in the spine by my first slide. I don't think it's very useful for the moment. Maybe in the future it is going to help us. Navigation. So how about navigation? So I think navigation can be a great, but my own experience, every 2 or 3 months, I was called in a room that's by one of the surgeons I work with. A navigation system doesn't work. It's well, can you go and help him put the pedicle screws? So I had to go back and just help my colleagues to put pedicle screws in a conventional fashion because the navigation system doesn't work. I do myself lots of navigation. I do lots and navigate a lot, but on my boat. And I'm always a little bit worried that the display on the screen is not the reality, that the chart on the is not the right thing, that the GPS doesn't work. And then when people tell me, oh, your accuracy is going to be 2 or 3 millimeters, I say, some pedicle on the concavity of the curve are only 1 millimeter wide. So how do you want me to put a pedicle screw that's going to be 5-6 millimeter wide of diameters in a 2 millimeter pedicle with an accuracy of 2 or 3 millimeter? Doesn't work. So I'd rather see the pedicle after my Smith-Peterson on me and put it safely by seeing it. And you have the patient movement as well. You have the other thing like skiving, everything. And then when the other problem is losing the skills of freehand screw placement. Some fellows who go to a place where they navigate every single screw, they move to another place in the country where they don't have the OARM, the navigation system, and they can't do any deformity because they just don't have they've lost all the skills to put the freehand pedicle screw. So I think this art of freehand screw placement shouldn't be lost. On the other hand, I would think that for previously fused spine, where you have lost all anatomic landmarks, its navigation is useful. You have some alternative, like you can use a C-arm to see your pedicles and hooks and claws in the fusion mask. That another alternative that you can do. Robotic surgery, there is definitely no question that it's one of the future. Just with the I drive a Tesla, and this is fantastic. I didn't pay for the full full auto drive, which costs $15,000, but I've got the semi-automatic drive, and obviously the cars in the future, you won't need to do anything. You will just stop, you'll press the button direction where you want to go, and it will just get you there, and you won't have to do anything. And this will happen in the future. However, now when I see a robotic surgery, often see a very small little wound that I don't think it applies to deformity for the moment. Maybe unless I should go and see people who do lots of robotic surgery who have far more advanced with this. As to the minimal invasive spinal deformity surgery, so Michael Wong just gave a fantastic talk, and I've been very impressed, and that's why I'm just going to do a fellowship. About the artificial intelligence, another breakthrough that everybody is talking about it. I don't know what to make about this, but there's definitely, if we look at the literature about spine surgery and machine learning, artificial intelligence, it's just unbelievable how much literature is out there, and it's definitely for predictive model. Okay, so for classification is going to be extremely useful. Predictive model, what you should do, definitely mining the database and with artificial intelligence is going to be a great tool in the future. I think that's machine learning, and I think that's it. So this is my reflection of the different breakthrough of spine deformity journey that took me from Paris, where I am now, as a matter of fact, to Pennsylvania Hospital, and that was 33 years of spine deformity surgery, and I've enjoyed it very much, but I still have many things to learn. Thank you.
What an experience and what a treat, Vincent. Thank you for joining us, and especially from Paris. And you may have been not present during the beginning. We want to feature the tremendous accomplishments of our French surgeons for the benefit of our spine surgery care. And coming from you, this lecture was particularly meaningful. Answer me a question that we're asked a lot, and that is, I think we heard about Rick Deo earlier. The criticism is that we're doing more and more big spine surgery. Is the population getting sicker, or are we overdoing surgery and then treating the sequelae of our own surgeries? What's happening in the big picture front as you look at 30 years of spine surgery and deformity surgery?
I mean, this is for Michael or for me? I can take this question. It's definitely the surgery we're doing now. We were not doing this surgery on this type of patient 20 years ago and 30 years ago. 30 years ago, Kostrik did publish the complication rate of adult scoliosis surgery, and he made a breakdown between less than 50 and more than 50. But now, when you have a 50-year-old patient who comes to your clinic with adult spine deformity, you think, oh, that's fantastic, it's very young. And this is, we're treating, I would treat a spine deformity up to the age of sometimes 80 years of age. Big construct, if they're healthy, if they have good bone health. And so we've been able to push the envelope. And are we crazy to operate these old people? Well, if we were doing a really, really bad surgery, nobody would come to see us anymore. So that means we still treat a majority of these patients. They're happy with the outcome of the surgery because they talk to each other, and then you see their friends and they come to see you. One of my most funny history is that a patient who came to see me, and he was totally bent over at 70 degrees, severe flat back. He was in a supermarket, and a former patient of mine just came to see the patient. I said, but you cannot stay like this. There's no way you can stay like this. Why don't you go and see Dr. Arlet? So, and this patient was in the, I think, late 70s. So this is really, really being a big change of our practice. We tackle this old population.
Predictive modeling. So I've dabbled with it, and I had the great privilege of serving as a visiting professor in your beautiful center. It was an honor. We still don't have really good predictive modeling opportunities. We put in millions and millions of data points, and we still kind of are in a gray zone where everything's kind of muddled. We don't know how patients will do. And for me, the amazing thing was always the patients, irregardless of their curve, have a positive mindset, somehow are very happy with their life, and there are people who are very unhappy with their life. They have anxiety, depression, they're very down. So where are we with AI predictive modeling, and are we really capturing what is essential for patients' happiness in terms of their backs?
So for the patient happiness, I don't think that artificial intelligence is going to change the way if people are angry at life or not. I think some people who are angry at life will always remain angry at life, and but the prediction is. I think it's going to be possible with artificial intelligence. We collect so much data that in the future it's a question of resources and being able to to interview the patients, look at his depression score, and have the staff to be able to gather all the data. So we should be able in the future to have a very good prediction model. I started the artificial intelligence thing 25 years ago when I had my ScolioSoft software. But at the time, everything had to be put in manually. So it was becoming impossible, and I was basically entering all the data manually. We managed to get 400 idiopathic scoliosis, but it was just too much work, plus a lack of funding and everything. But nowadays, everything is going to be through machine learning, and the machine is going to recognize everything, the curve. I don't think classification would matter anymore very soon, because the machine is going to cluster all the patients who have the same curve, and then is going to tell you, well, that's a good outcome and that's a bad outcome. So it's going to be automatic.
Yeah, good answer. Final question, then we have to go to the lab with John Dimer. I think they're ready in the lab. And that is the dynamic banding of usually adolescent spinal deformities. You credited Randy Betts with this, and I was at Global Spine Congresses recently. They showed the first couple of papers where they showed multiple serial failures of dynamic tension banding of adolescent spinal deformities. In your prognostication, having seen a lot of trends come and go, are we just kicking the can down the road? Are all these rubber-banded patients going to fall apart and then need fusions eventually? Do we actually have a benefit, or is this going to push the curve towards surgery further into being a little bit over-aggressive maybe in surgery?
I haven't seen yet many patients myself with just the tether breakage, because I don't do this type of patient, but definitely it's out there. And when you see the evolution of techniques, it's still, they change all the time the technique. Before that, they were doing double curve. Now they fuse the thoracic curve and do a tethering of the lumbar curve. They put two tethers, so it's a change. So there are some issues. Now, what's going to happen in the long term? Well, we're going to have to do a revision. There's no question about it. But the idea is brilliant. You have cases that are fantastic. So I think it's going to be here to stay. The indications are going to be need to be more precise, and technology probably improved. But I think it's there to stay for very good and specific indications.
We've had over 400 live viewers, and Dr. Farag Basha has been very active in the chat room. I want to thank him for as many questions. You showed some very big cases. If you do such a big case, do you have a limit in terms of physiologic parameters, like 2 liters blood loss, 3 liters blood loss? Any other physiologic parameters when you stop a surgery and stage it to not overwhelm the patient and create like a polytrauma situation with a major spine surgery?
I think it's important that you have some limit to the surgery you're doing. For me, my limit is we shouldn't exceed a maximum 1.5 or 2 liter of blood loss, and your surgery should always be finished at 5 o'clock. And so otherwise, I'm going to stage it. So I don't mind doing a front and back on the same patient, or lateral, or whatever it is, but it has to be finished at 5 o'clock. For multiple reasons, because of the surgeon fatigue, the team fatigue, the change of the team. And I'm not as good a surgeon at 7 o'clock in the evening after 12 hours of surgery that I'm just as good as at 7 o'clock. And if I have to do a complex revision, a decompression in a scar tissue at 7 o'clock in the evening, I'm going to get a dural tear, that for sure. Usually I don't get a dural tear, but if after 10 or 11 hours of surgery, I'm probably going to have one. So I think it's important to know your ability to do surgery and the patients, what can the patient withstand. And if I think if you think the surgery is going to be too long, you should, between the front and back, you should stage it. You should do first the lateral or the front, and then a few days later you do the back. It's only when you become proficient and you go fast enough that you can do it in one day. And the threshold of 1.5, 2 liters, I think that's a maximum. Afterwards, you start to run into problems.
Great answers. Thank you so much for this amazing overview. And we will proceed now to the lab.